Okay. I'm Rhonda. Most of you guys know me. I'm one of the vascular access nurses. I've been here for 20 years doing vascular access. And I was asked by Amanda to talk to you about when to escalate to central access, like when patients need that, right? Do you guys have any like off the cuff questions before we even jump into it? Like what scenarios have you come up with that you're like, I don't know what to do here, or? What's your situation right now?
I'm about to give birth, but she has ultrasound guide that's in for 7 to 8 days.
For 7?
7 to 8 days. I'm trying
Okay,
to figure
okay.
out.
Yeah. So then you're like, okay, what do we do next, right? So I gave you this necessity tool that I created for our team when we started getting asked to pull central lines, right? And put peripheral IVs in place of those central lines. And so this is from the policy, and it's also from the Infusion Nurses Society Standards of Care, which is what you're held to in a court of law. You guys all get that. Like, if you go to court over a case, they're gonna look at what your standard of care is and did you follow that or not. Your policy can get into that as well, so you have to follow policy. So our standards are reflected in our policies. So this comes directly from the standards, which are reflected in our policies, okay? I also use the Michigan Magic guidelines as a reference because that was put together by a group of hospitalists. It was a meta-analysis of all like 500 and some odd studies that were done about different lines and their outcomes and clinical complications and such. And so in that, it follows the same patterns. They found the same thing that we've been finding for years and what I was taught as a baby pick nurse 20 years ago, okay? It hasn't changed. It hasn't changed. So the first thing that we look at is the anticipated duration of therapy. So if your patient's going to need IV access for more than 5 days, CDC guidelines, Michigan Magic, all those folks say you really need to consider central access for that patient. More than 5 days, right? Now we do have midlines now, which can be useful as an intermediary. So if you need access for up to about 14 days, a midline's probably good for that. If you need to go beyond 14 days, a midline's probably not gonna work. And you guys, if you've worked with midlines before, you know that they lose blood return in about 2 or 3 days, so that's gonna complicate things.
You
Yes,
can't
ma'am?
like nothing go through it.
Yes. And
So
that's,
I'm like,
that's where we get into, okay, what are the infusates?
yeah.
So the first step is just like, okay, is this gonna be appropriate for short term, which is what peripheral IVs are designed for. They're not designed for long term. And the reason for that is the flow rates, right? Flow rates in the hand is about 20 to 40 mils per minute. And the forearm, 40 to 60 mils per minute. The flow rate in the superior vena cava, where we put the tip of central lines, is 2,000 mils per minute. So it's 100-fold slower in the hand than it is here, right? Okay, so that's why there are some medications we can happily put through here, and they're gonna cause amputations of the hand if we put them in the hand, right? So that's the big thing. When you're going for more than 15 days, and you know that you need access for more than 15 days, that's when we get into PICCs. We start getting into tunneled lines, right? So if somebody needs like 3 months of something, or they're gonna be on chronic TPN, or they're gonna be on Remodulin or something like that for pulmonary hypertension, that's when we start getting into PICCs and tunneled lines and that sort of thing. Because they can stay in for years, years.
All right, cool.
If it's intermittent infusions, like our chemo patients, that's when we put ports in, right? So if you know somebody's gonna need 6 months of something, but it's not gonna be consistently accessed, that's when we opt for ports. If they need continuous access, that's when you want more of a tunneled line or a PICC. Now, PICCs are challenging, right? Because they're in the arm and showering and all that stuff and manipulating. If somebody has a tunneled line, they can actually do the dressing changes themselves up until the point that it heals. And then after that at home, a lot of those patients don't have dressings on those lines, right? It'll just be open because there's a cuff that's preventing the microbes from growing into it. The cuff forms adhesions with the tissue in that subcutaneous space, all right? So a tunneled line is actually kind of a better line for somebody that we know is gonna be on continuous infusions for a year or longer, right? A PICC is normally more like maybe up to 3 months, just because it's more of a pain for them to deal with, right? All right, so time frame is first. The next thing that we look at is the medication list, right? And that's to your point of there's a lot of stuff that you can't put through midline. So that list that I gave you of vesicants, that's all stuff that you should not be putting through midlines. Okay? So the high risk column, the one in red, those are medications that, when given peripherally, have caused extravasation injuries that have caused prolonged functional damage for multiple patients. Okay, that means that they had an amputation or they had a flap that involved a joint, and so now they don't have full function of that joint. Right? So that first column, high risk. We know there are lots of problems with it. The middle column is moderate risk. They have had more cosmetic damage from their extravasations. Okay, so those you might be able to get away with for a little bit longer through peripheral devices, but they're often also irritants in addition to being vesicants, and so they're damaging the veins, which is a lot of times why you can't continue doing them peripherally. All right. The cautionary column, we're not sure if it was this medication or this medication combination that caused some of the damages that we're seeing there. There have been some functional damage from some of those cautionary medications too. So it's not all just cosmetic damage from those, but there's just uncertainty about what it was. And as new medications come on board, these extravasation injuries and such don't always pop up during the case studies, right? So especially if you're administering newer medications, or we change the route of a medication. So like Phenergan and Valium and Robaxin were all IM medications when they were approved by the FDA. And we started off-label using them as IV medications, and eventually we're giving them IV all the time. But it was in that process that we missed that they were vesicants, right? And we started seeing damage. The same thing can happen with any new medications as they're being produced, because they can't possibly see all of the potential complications from drugs, right? So just because it's not on the list doesn't mean it's not a vesicant. And that's the thing to keep in mind. If you were seeing tissue damage from a medication infiltration, it's potentially a vesicant, and that needs to be reported to pharmacy so they can report it back to the company and the manufacturer so they can figure out what they need to do, if anything, okay? So, vesicants, if they're gonna be going for more than 24 hours continuously, that's an indication for central access. And we get that from the Michigan Magic guidelines. There is an app for that. It's called the Michigan Magic app. You can dial into that and if you put in that they're on a vesicant or an irritant, it's gonna immediately say they need a PIC or an IJ. It doesn't offer, oh, peripheral's okay for 4 days or whatever. It doesn't say that, period, end of sentence, okay? We changed our policy on vasopressors so that they could run through peripheral IVs for up to 24 hours. That's to give us time to get the central line in so you're not going against the policy. That's not like, hey, everything's grand. If you look back at those veins that those vasopressors have been running through with the ultrasound, you see vessel damage. Like 100% of the time. I've never seen a patient who was on Levophed that I looked back and was like, oh wow, this vein is pristine. They're not, they're getting damaged, okay? So can you do it? Yes. Is it safe? No, not in the long term. If they're getting more than 2 doses of intermittent infusions of vesicants, that's also an indication. Okay, so a lot of those medications, especially in the middle column, are intermittent. They're not a continuous infusate. So if they're on those, then we need to be considering central access for them, especially if it's going to be ongoing. Right? So vesicants are kind of straightforward, especially if there are multiple vesicants. You probably need central access for that. Irritants are a different story. Irritants damage the inside of the vein. Usually if an irritant leaks out, unless it's a vesicant, it's not going to damage the tissue in the surrounding area, right? So irritants are what cause infiltrations. If you're combining irritants and vesicants, that's a problem, right? So an irritant makes the vein angry, it makes the glycocalyx reactive. When the glycocalyx gets reactive, it starts telling the body, hey, we need fibrinogen and platelets and all this other stuff, and the vein starts becoming porous. When the vein becomes porous, that's when you start having subtle infiltrations, right? So if you're putting an irritant through and then you're running a vesicant through, for example, cefepime and vancomycin, right? Cefepime is an irritant, vancomycin is a vesicant and an irritant, right? So it's more likely that that's going to infiltrate and then cause potential tissue damage, right? So if you have an irritant and a vesicant, the recommendation is 2 separate IVs for those. You're going to be able to give more doses through that. Now, I just told you for vesicants, if you're doing more than 2 doses a day, that you should get central access. Why am I now telling you peripheral IVs? Anybody know? Why are we giving vancomycin and cefepime a lot of times?
We're waiting for cultures.
Exactly. And if we're waiting for cultures, a lot of the infectious disease doctors don't want to go ahead and put a PICC line in, because then there's the potential for seeding that line if the patient does have a bacteremia. The studies are kind of like, Sean, maybe that's not true, but we don't know yet. And so ID is still being cautious about that, and they're still like holding off on getting that central line in. So we may have to do peripheral access until it's appropriate. Normally about 48 hours of negative blood cultures, the docs are gonna be like, okay, we can do it now, or we're gonna stop those antibiotics. We don't even need them anymore, right? So we have a little bit of a window of uncertainty until we kind of know best what's going on with the patient, right? So that's where this next piece comes in. If you're doing daily site rotations on a peripheral IV, you need other access, right? That's not appropriate. How many times is it okay to stick a patient during a day or hospital stay or like, right? If you look how many times our patients are getting stuck, we routinely are poking these folks like 25, 30 times over a 5-day stay. And we wonder why they're all like freaking out about getting poked. I've had 3 patients, exactly, right? I've had 3 patients in the last 3 days who were just like up here and freaking out from me doing a line. I haven't had that in 20 years. When I first started and we were just really starting to kick off on doing PICCs on folks, that's when we were doing it. But now we're doing all these peripheral IVs again and poking the snot out of them because we don't want them to get CLABSIs, right? And I get that, but we also can't err on like stabbing them to death. My mom just left AMA from a hospital a month ago because she was like, no, they're not poking me anymore. I'm out. I'm done with this, right? So that's the other thing that we've got to consider is like, are we going to be able to give them the care if we don't have the access, if they won't let us put the access in them? So if you're requiring daily site rotations and you're having failures, you're more likely to get more failures. So if you have phlebitis, you're like 60% more likely to get phlebitis again because it's the drug that caused the phlebitis, right? If you have an infiltration, you're like more likely to get another infiltration because it's often the drugs that are causing that infiltration. So failure is going to beget failure. The other things on here are like, okay, once you get past those, the other things are is the patient hemodynamically stable? If they are, maybe you don't need central access. But like in ICU, a lot of those patients are unstable and need access. So we're looking at vital signs. We're looking at, do they need like dialysis, pheresis, are we doing CVP pressures? That's ICU kind of stuff, so not really pertinent to your decision making. But then we look at the compatibility of the medications, right? So if you need 4 IVs because you've got incompatible medications that aren't supposed to be running and you need to give them at the same time and you've talked to pharmacy and they can't change the timing of it, you might need central access for that, right? Most of the time those are also vesicants and irritants when that's happening, right? So it almost always reverts back to what are the drugs that you're giving. When you require site rotation on medications, not a lot of them say that in the book, but some of them will say, hey, this one needs site rotation, and that means a whole new site. It doesn't mean you swap the vancomycin and the cefepime and put them in the opposite sites now, right? That's what we were doing for years, guys. So I'm being cute, but also not, right? So you need a whole new IV if you need to rotate that site. Chemotherapy, we know that. And then if you've got limb restrictions, end-stage renal disease patients, the line of choice for them, if they need IV therapy, is a central line. It's an IJ, right? If we're putting IVs in the opposite arm, if they've got a fistula over here, we're not putting anything in it, right? We're not poking it, so we don't want to infect that. So if we're having a poke over here, we're compromising their ability to get a future fistula. Fistulas only last about 7 years, and then they need to replace it, right? So if we compromise the vasculature over here with our peripheral IVs, that means they're not going to be able to get that fistula. Now, some folks are doing fancy thigh fistulas and stuff like that. I haven't seen one here in Texas yet. They're doing that up in the Northeast and the Northwest. We're not doing that here. We're too country for it or something. I don't know. That's probably not true. So IJ, if they're gonna need longer term therapy. If it's just short duration, the hand is the most appropriate place on the CKD patients. But what's the flow rate in the hand? Right? It's low. It's low. So if we put irritants through there, they're more likely to cause thrombophlebitis in the hand. And when it starts leaking out, compartment syndrome is a big risk here, right? So the hand doesn't hold a lot of volume. So it will start pressing on the compartments and impact nerve function, tissue function, can mess up tendons and stuff like that. Yeah.
I have a question. What about like if there's a vesicant and a irritant that are like compatible, running them together in the same line, does that make it like extra bad?
Irritating to the vessel, yeah. Yep.
Not doing that.
That's like a sinner.
Like bacon stuff.
Like vancomycin, right? And cefepime is one of the most thrombophlebitic drugs I've seen. I literally have seen thrombosis from wrist to axilla, both arms, all veins from cefepime. Because we were just like, well, it's not a vesicant, so we're just gonna keep rolling that through the, but people weren't paying attention to how many IVs they've had. And that's the question I ask you. Do you know how many IVs your patient's already had? Most of the time the answer is no. Do you know where to find that information?
Yes.
Good.
Right.
You go to flow sheets. You go to flow sheets and line views, right? That's where you go to get it. And a lot of people are like, oh, I never used that view before, right? So if you're coming in and your patient's on vesicants and irritants, you should look at how many IVs they've had. I always look at that. I look at the drugs and then I look at how many IVs they've had. And then I have the conversation with the provider. Here's what I'm seeing. Patients had this many IVs, they're on these medications. What's your plan of care? Are you gonna stop those drugs later this afternoon? Cool, we don't have to do anything. If you plan all those medications continuing, then we need to do something different because the patient's getting harmed, right? So is it black or white? Like making these decisions? No, I wish I could just be like, here is an easy pathway for you to follow. But it's a lot of critical thinking to like figure out what the best line is. If you're not sure what your irritants are, there is, and you guys, if you've been to one of my classes before, you probably used this QR code and have that BD app loaded on your phone. It tells you what medications are irritants and vesicants. So if you're like, I don't know, this is the best vesicant list because this is the most up to date, all right? And it's all delineated into high risk, moderate, and low risk. Let's see, what else? What other questions do you have?
I have a question.
Yes, ma'am.
Do you have any recommendations for if we've maxed out our pokes for policy and the providers are recommending we continue to work?
Tell them that's against policy.
Or, oh,
So, and the policy is 2 people get 2 attempts. And the evolving standard of care is you stick twice, and then you refer to an ultrasound inserter, right? So that's the evolving policy. I think when the new standards come out, that's probably what they're gonna say. 2 attempts and then send it to an ultrasound inserter. Because we know when you add in the ultrasound, your success rate goes up. And if we add in the ultrasound and the success rate isn't going up, that tells you everything you need to know about that patient's vasculature, right? So your potential for success is not gonna go up by continuing to poke them. And you're putting holes in veins that somebody might actually be able to come through and get access on. So if I've poked everything up here, where are we gonna go? Because the rule is start low and work your way up, and you don't go below previous failed sites. If you're using the vein finder, you can be like, oh, well, that vein was poked here, so which vein below there would I poke? None of them, right? A lot of people are like, oh, put it in the hand. This vein goes communicates right there, and it's gonna leak out here. And then when you're looking for infiltration, it's not gonna be here, it'll be over here where that other hole is, right? When I look at where those IVs have been, it's almost always AC, forearm, forearm, wrist, hand. That's the order that we go in, which is the total opposite of what we all learned in nursing school, right? The absolute opposite of that. And so that tells me that we've got little micro infiltrations that are happening all the time.
How long does it take for
A phlebitis to heal. So it can take up to 6 weeks. You guys know Marcel from 6th Floor? Marcel Carrier, big burly guy. You probably worked with him. He came to the ultrasound training class, and he said that he had gone for something, I can't remember what it was, and they had done an IV for him, and it was an outpatient setting, and he got phlebitis from it. He said it was still hard up to like 4.5 weeks later. He said it didn't fully resolve for 6 weeks, and he is a super duper healthy guy, right? So our patients, you know, I can take up the, what's that?
I have one that was hard for 3 years.
Yeah. So it sort of depends on the healing process. My mom got an abscess from one of her IVs, and it was firm for like 2 weeks. Well, there was an abscess for like 2 weeks, and then it started kind of going away, but like I couldn't palpate the vein after that, so the vein was just.
So I have a question. They come in with 2 ER, so that's it? Just call you guys?
Use your vein finder, right, and see what the vein pathway is. So if the IV is here, that usually means the cephalic is not an option. Sometimes it means the median's not an option, right? It's the best one. I know, right? It's my favorite. It's my favorite. I'm like 80% of the time, that's where I am. You may be able to access the basilic over here. That avoids that though.
Okay.
So use your vein finder and look, because sometimes the basilic will do this weird thing where it splits, right? So it depends on where their puncture was and where you're able to access. So if it splits here and it goes this way, then you can access right there.
So even though they haven't infiltrated, they do have a hole?
There's still a hole.
And so that could?
Yeah, and if they haven't put anything through it, cool.
Nothing.
Then leave that IV out for 24 hours and that's probably gonna heal. So if it's just a stick, a venipuncture, we're not putting anything through it, that's gonna damage the vein, those usually heal pretty quickly. Anytime I've looked back with the ultrasound at an AC that has been in for more than 36 hours, the vein is always like, yuck. It's phlebitic, there's junk inside of it on the ultrasound, okay? Because of this, right? And they're banging against the vein wall. And the glycocalyx is going, send fibrinogen, send platelets. We've got to repair the damage that's being done here, right? So that's why no ACIVs. And I just yesterday I said 2 horrible thrombophlebitis from ACIVs that they had unwisely left in for 7 days. I'm like, guys.
Sorry.
I know, right?
I love how reaction up here is.
Hey, I know.
Never fly.
I know, I love you guys. What else? One of the things that you can do when you're talking to the provider is talk about the medications, their vesicants, their irritants, but also what's the patient's experience been. A lot of times, if I tell the provider, oh, well, they got stuck 17 times overnight, they're like, nobody told me that when they requested the PIC. And I'm like, oh, they're like, yes, do it. And I'm like, okay, cool. Right? So if they know what the patient's already been through, they're more likely. But do pay attention to the plan of care. Like if they're getting discharged this afternoon, probably let's not put a PIC in them today unless they're gonna use that at the SNF or whatever, right? Did I hit all the topics you wanted me to? I know, right? You guys get burns on this floor? So those are tough, right? Especially because they're usually burned up here. We are working on a mid-thigh protocol to place PICs in the mid-thigh. There are a few of us that are like gonna be the go-tos on that. If you find that situation, just let us know and we can see if that's an option for them. The challenge is that's where a lot of times they take the skin for grafting too, right? So we gotta coordinate with the burn team on that, but that could be an option if their arms are all burned up.
On the outside.
What's that? The
Because
graft?
they usually take like skin from the outside.
Usually don't, unless they're all burned, then they'll take it, but.
Yeah, I was just thinking of the one that I saw that I went to the OR because they were like, can you come put a line in? And I watched them. I was like, okay. It was kind of, I was like, that patient's gonna get a bacteremia, but okay. Let's see. Fractures and mastectomy. So if they've only got one arm, like lean into, they're probably gonna need central access if they need IV therapy for more than 5 days. And that's a CDC guideline, like from forever ago. You know what it's based on? It's based on when peripheral IVs go bacteremic. Takes about 4 days, right? That's why at 4 days you start seeing positive cultures sometimes. Right? So we changed our policy to allow peripheral IVs to dwell for 7 days, right? Well, that was predicated on that you're doing an aseptic non-touch technique for your IV insertion. If you watch what people are still doing, it's not an aseptic non-touch technique. They are like fingers all over everything. And especially if they're using one of the straight stick BD and not the Nexiva with the wings, there's no way to attach that loop to the hub without touching right there at the bloodstream, right? So if those are the devices that they're coming up from the ED with, you want to get those out still in that 24-hour period and get a new device in them. Those aren't ones that you want to allow to dwell. Now, when we're doing the ultrasound IVs, everybody has been trained to do them with the aseptic non-touch technique. I wish that I could say everybody's doing that, but I still see some stuff on that too. So if it's not charted as ANTT, you got to question it. And that doesn't always mean that it's going to last, because what's the difference between an ultrasound IV and a regular IV? Just that you use the ultrasound to get into it. It's the same veins, they're just deeper, usually because of the patient's tissue, or we're using the ultrasound because they're a tricky stick.
Sorry. Like
Please.
same thing for like the midlines. Do you think like ultrasound IVs we shouldn't use like if like the vesicles through just can't really tell when it's infiltrated as much?
It depends on where it is, to be honest. So if an ultrasound IV or a midline is here, then yes, I would not give vesicants through it. If it's through this area, it may be okay. So I would ask the inserter, like, how deep was the vein? If they're using, a lot of times when we're using the longer catheters, it's because the vein is deeper. That's why we started documenting the length. So it sort of just depends on, like, your ability to assess. It is going to take longer for you to see the inflammation and stuff that's happening with an ultrasound IV. Yeah. So I can't say no, but if it's one of those continuous infusions of a vesicant, I'd be more cautious about it for sure.
Are all of the ultrasound guided IVs still getting the CHG dressing?
Yes, they should be. Yeah. I made that face because I did one yesterday that I didn't because I forgot to drop it, but I had a different large dressing on it, and so I was like, except for that one I did yesterday. Cool.
We put in a request for a PICC line or ultrasound,
Uh-huh.
and you guys can't come till tomorrow. And can we still do the best we can with the peripheral, knowing it's just gonna be 1 or 2 doses?
So if you have vesicants, you want to have blood return, right?
Okay.
If you don't have blood return, what's happening inside the vessel is you've got some degree of thrombosis, the glycocalyx is angry, and that's causing it to be subtly leaky.
Okay.
So anytime you don't have blood return, your vein is probably subtly leaking, okay?
Okay.
It's not like the whole thing's blowing, but just a little bit, right? So I would be, for those, if you can get something in and you've got good blood return and it flushes easily, okay.
Cause that happens a lot.
Yeah, be careful about where you are in relation to the previous IVs though,
Uh-huh.
right? Because that's the thing that I see the most is we lost it and then we had to go below it.
Uh-huh.
And a lot of times, these veins down here are now more prominent because of the damage that's been done up here. And so the flow through here is slowed down, which makes the veins more distal, more prominent.
We just need a central line on everyone. Pretty much.
Yeah.
We do. We really do.
Yeah,
Or-
and the
or-
utilization rate thing has really kind of messed that up since we're being held to this standard, but it's not based on the medications that we're infusing. It's just like this number that's like, hey, you want to follow this number. But it's really got to be about what you're giving through it. And I don't know if we just give different medications here than what they do in the Northeast and Northwest, where they're supposedly able to do this without central access, which is where a lot of the data comes from. But I don't know. I mean, it could be that. It could be that they're reducing their concentration so they're not as caustic, or
Yeah.
they're doing them for shorter terms or getting things turned over faster. I don't know.
Okay.
These are tough questions that are happening all across the country. You guys are not the only ones that are like, what do we do? So,
The best we can.
exactly, the best we can. We'll help however we can.
We need some more of you guys.
Girl, tell it.
I will.
So if you get that situation where
A lot, we get
where
a lot.
you've asked for it and we can't come because we're not staffed or whatever, especially if the patient's missing doses or something like that, do an ERS. Like, that's how we're gonna get
Okay,
more staff, because
okay.
our staffing is based on like the census,
Yeah,
right?
okay.
Well, the census is just
Just
like,
2 doses.
yeah.
And 2, yeah,
Yeah.
okay. Yeah,